Back, everyone. This is our oral session 1 for ShowCAIS 2026 with a focus on talks on mental health, clinical health, and public health. Our first speakers are Yahan Lee and John Bunyi. Yahan is from the Viterbi School of Engineering, and John is from the School of Social Work.
Oh, okay. Hi, everyone. My name is Yahan. I'm a PhD student in computer science, and this is my collaborator, John. He's a PhD student from social work. So today we'll be presenting our work, CounselBench. It is a large-scale expert evaluation and adversarial benchmark of LLMs for mental health QA, and this is a joint project with a broader team at USC spanning computer science, social work, communication, and psychiatry. So it's really been a collaborative effort. So firstly, I will invite John to introduce the broader social context behind this project.
Awesome. Thank you again for the introduction, Yahan. And good morning, everyone. My name is John Bunyi, and I'm a mental health clinician by training. And as folks have mentioned, PhD candidate in the School of Social Work, where I study digital mental health interventions. And I'm here to talk about, as Yahan mentioned, the social sciencey side of the project and the sort of real-world challenges that the work seeks to address. So looking broadly, LLMs have become embedded in nearly every domain we can imagine, from business and customer service to travel, education, and healthcare. But one area that's of particular interest to us is the field of mental health care. So people are already turning to these models and tools for emotional and psychological support. And that does raise the important question, which is, are these models actually any good at it? And I think I heard earlier someone mention a similar question during the keynote. And so the problem is that benchmarking LLMs in mental health is genuinely hard. So unlike a coding task or a math problem, there's no single correct answer in mental health. Responses need to be empathetic, appropriately toned, and importantly, safe, right? And so a model that confidently gives the wrong kind of advice could cause some real-world harm. And yet, question and answering, or QA, remains the core medium of interaction for these tools. So to understand why mental health is particularly tricky, it helps to contrast it with physical health questions. So when someone asks about their A1C level, or dieting, or perhaps a weird knee noise, there's actually a factually grounded answer. And the model can be accurate, specific, even a little funny, and that generally works. Mental health, though, is a different story. It's a lot trickier. So when someone says, I feel off, but I don't know why, or they're lying awake at night, spiraling about a mistake they made a while back, the right response isn't just about being factually correct. It needs to meet the person where they are emotionally, avoid over-pathologizing, and know when not to intervene clinically. And so that's a much higher bar, right? And so this isn't just a hypothetical. People are already doing this at scale. Roughly 24% of the sample reported using LLMs for mental health support, and that number jumps to nearly 49% among people who regularly use LLMs at all. So the question of how well these models perform in mental health question and answer goes beyond academia. And this is a real-world challenge happening right now, and that's what CounselBench sets out to answer. And so I'll hand it back to Yahan, who will walk you through how this benchmark was built.
Thank you, John. So to answer the question, how do LLMs perform on social health, mental health question answers, we present CounselBench, which includes 3 components. The first one is CounselBench Eval. We provide expert evaluation on LLM responses. And the second one is LLM judge analysis. We test if LLM themselves can serve as the reliable evaluators for those responses. And the third component is CounselBench ADV, where we build an adversarial benchmark targeting on the failure modes we identified from CounselBench Eval. So for CounselBench Eval, we focus on 6 dimensions. The first one is overall quality, and the second one is empathy, specificity. Specificity is how well the response is tailored to specific user queries, rather than just providing a very generic response. And the fourth one is medical device. The reason we highlight here is we realize that LLMs are not licensed therapists, so the user should be extremely cautious about the medical device they provide. And the last two are the factual consistency and toxicity. Toxicity is if the language shows any potential harmful. So we first gathered 100 real user questions from the online platform CounselChat, paired with their most upvoted human therapist answers. And then we recruit 100 mental health professionals across diverse credentials and specialties. So as you can see, like over 70% of them are licensed therapists and counselors, and all of them receive professional counseling training. So each response is annotated by five experts. So here's the results. The right area here are the scores gained by the human therapist, and the yellow one, the green one, and the blue ones are the scores gained by different LLMs. So surprisingly, LLMs performs better than the human therapist. And for example, for the blue one, the Llama 3.3 received the highest overall score. However, performance doesn't indicate safety. We do observe that LLM provide like specific unauthorized medical device, for example, providing very specific medication suggestion to the user. So by now, all those evaluations are based on the expert annotation, but expert annotation is expensive and not scalable. This raises a natural question: can we scale up the evaluation by using LLMs themselves as a judge? And in other words, can LLMs reliably judge the quality of responses? The short answer is not really. So we experiment with different LLMs. The blue lines are different, the scores provided by different LLM judges. The red line are the score provided by our human expert from the first component, CounselBench Evolve. So, and here we highlight the score, the dark blue one from GPT-5, because we think is better aligned with human annotators. However, as you can see, most LLM judges doesn't align with human expert. Like they usually overrate the response and miss safety failures. For example, they overlook more medical device and toxic language in the response. And the rankings provided by LLM judges really diverge from the human preferences, and they really flag the problematic sentence in the response. So this shows a really challenging problem for the LLMs themselves to provide reliable evaluation on the mental health answers. So further prove the failures, we identify 6 failure modes from the CounselBench Eval, which includes providing specific medication suggestion, like speculating medical symptoms, being apathetic, being judgmental, and using unsupported assumption, or providing specific therapy techniques. And we ask our expert to craft it another adversarial data set targeting on the 6 failure modes we identified. So here's the result. On the left here is the 6 failure modes we identified. This table shows the frequency of failures. So first of all, we observe the patterns across model family except for GPT family. So for Llama, for Cloud, for Gemini, as you can see, those models within the model family, they show similar pattern of failure. And we further show that those issues may not easily be solved by just providing good examples. So this really indicates the limitation for the model alignment. And for future work, we think it's really necessary to provide the benchmark that is targeting on real-world use instead of just for the idealized setting. And here is our references. So thanks for listening, and we are happy to take any questions, or we will take it in the end.
Actually, yeah, so the speakers will all take questions at the very end of the session. And so please come back to the podium. The next talk, speakers, please come. The next talk will be by Vidur Mushran, who is an undergraduate affiliated with CAIS, or our undergraduate wing, CAIS++, and Sonya, who's from Kaiser Permanente. and they will be talking about interpretable machine learning for early substance abuse risk prediction in pediatric healthcare.
Yeah, it's nice to see everyone today. I'm Vidur. I'm an undergrad studying at Dornsife, and I'm here with Sonya, and we're working on interpretable machine learning for early substance abuse risk prediction in pediatric healthcare settings. Sonya is going to take it away with establishing kind of the context.
Hi, everyone. Yes, my name is Sonya Negriff. I'm a research scientist at Kaiser Permanente, Southern California. I'm very happy to be here in collaboration with USC and share some of this data that we've been working on. So substance use is a very large problem. We know that over 7 million emergency room visits are attributable to substance use a year, as well as over 250,000 deaths. And this translates into a cost of $740 billion a year due to accidents, unemployment, healthcare costs, homelessness, and criminal activity. Now, importantly, adolescence is actually a really key opportunity for prevention of substance abuse. As data show, 90% of adults with addiction actually first initiated substance use in adolescence. The data also show that child maltreatment is a known risk for drug use. Now, child maltreatment collectively is experiences of physical abuse, sexual abuse, emotional abuse, and neglect. And these children are often referred to child welfare as a result of these experiences. And the data show over 500,000 children a year in the US are reported to child welfare. Additionally, exposure to child maltreatment has been shown to increase the daily risk for marijuana use by over 2.5%. So clearly this is a very vulnerable population to this issue. There's also been a lot of research on the risks for substance use in adolescence. However, all of this data has been done with normative populations with community samples, not particularly with child welfare youth. These have been kind of bucketed into groups of parent and family risks, peer risks, schools, and neighborhoods. However, the very little amount of research that has been done with child welfare youth essentially show that the risks may differ for this particular population. And so we really want to understand what are those risks or protective factors for this particular population, because we want to better be able to target prevention or intervention efforts. So essentially this project was really focused on trying to see how can machine learning help us gain insights that we don't yet have into marijuana use in adolescents, and particularly in child welfare adolescents. So this project essentially integrated two sources of data. We have a small, very well-characterized data set that oversamples for child welfare youth, and then we also used electronic health record data, which has kind of less of those nuances of potential protective factors, but is larger and it actually has a real-world clinical healthcare setting implications. So essentially for this project, we wanted to derive this empirically, the set of risk and protective factors for marijuana use in adolescents. Then using machine learning, we wanted to look at compare the shared versus unique variables selected as important risk factors for marijuana youth, and looking at that contrast between child welfare and non-child welfare. We also really wanted to highlight age differences. So early adolescence, in particular, use during that period is a risk for escalation to later substance abuse. Later adolescent risk is not necessarily as risky. And then finally, the ultimate goal is to use this information to develop a risk score that can aid clinicians in their clinical practice to identify and target prevention efforts. So the first data set we used is called the Young Adolescent Project, and these data were collected at USC when I was a graduate student here. And this was a longitudinal study looking at the effect of child maltreatment on adolescent development. So we had 4 time points of data from 2002 to 2015. And as I said, they were oversampled for child welfare status. So 2/3 of our sample were referred from the Department of Children and Family Services, and 1/3 was drawn from the community, the same zip codes as the child welfare sample. Our outcome for this particular analysis we're looking at is marijuana use in the past 12 months. And as you can see here is essentially the prevalence of our sample by age bands, as well as the prevalence of marijuana use for the child welfare. You can see it's higher as expected, and higher for the older adolescents compared to the younger. So we grouped our risk and protective factors into these categories. So demographics, mental health, risk behaviors, protective factors, adversities, peer risk behaviors, family environment, and neighborhood disadvantage. So this is a lot of information. I'm just going to kind of skim over. Our models, these are results collated from SVM models. Overall, the models performed well, as you can see by the AUC. What I want to hone in on is just specifically the shared and unique risk factors for the youngest age group, so kind of targeting that early detection. And essentially what we find is the shared risk factors, the shared factors are risk behaviors such as sexual activity, peer risk behaviors, and mental health. Child welfare specific risk factors were found to actually be, we found some protective factors, so competence and self-esteem, as well as family environment. The non-child welfare specific factors were child sexual abuse. So as you can see, there are some differences between these two groups. So then we wanted to kind of use this information and apply it to a larger data set, which is our electronic health record in Kaiser, Southern California. This is a very large healthcare system that we serve over 1 million children and adolescents. The context of healthcare screening, substance use screening in Kaiser right now is that it is done, but it is done inconsistently. It is also hampered by low rates of disclosure. Adolescents often don't want to tell their pediatrician that they're using substances. So essentially, we wanted to apply these predictive models in order to develop a risk score that could aid clinicians in identifying at-risk adolescents.
Yeah, so this brings us to our Kaiser Permanente cohort. This was composed of all patients aged 13 through 17 between 2007 and 2019 who had at least 1 year of membership at Kaiser Permanente, Southern California, and at least one visit with another visit in the next 2 to 12 months and the previous 2 to 12 months. This gave us around 66,000 patients and 270,000 visits. As you can see, unlike the previous YAP data, there's a far lower prevalence of child maltreatment. In this case, we're using child maltreatment, which is denoted by ICD diagnosis codes and some NLP-derived features from clinician notes, as well as an outcome of substance abuse, dependency, or unhealthy use instead of marijuana use, none versus any. And it'll be use within 1 year of that visit. The modeled risk factor groups are similar. They're based on our earlier study: demographics, mental health, risk behaviors, adversity, family environment, neighborhood disadvantage. And our models exhibit pretty consistent performance. You'll notice that logistic regression, lasso, XGBoost, they're much simpler models. They're built to be used in an inpatient setting on EHR data directly. So we didn't want to use necessarily large, computationally expensive models. They still achieve relatively performant AUC scores across both the child maltreatment and non-child maltreatment cohort. And then as our planned prevention efforts involve no risk of harm, we're prioritizing a high recall. We're trying to capture as many at-risk adolescents as possible. And in turn, we accept a lower precision to avoid missed cases, which means we might make a positive prediction where a patient may not go on to use substances or abuse substances. And we found that lasso provides the best balance for that. And it identifies 68% of all patients at risk due to child maltreatment and 75% of patients as a whole. To give you a scale of the problem, around 38% of visits are flagged as opportunity to intervene, and every 6 flagged visits we can prevent substance misuse.
Yeah, so what are the next steps here? Essentially, we need to understand these models because, as Vidur showed, there's, several different models that we were testing. So we want to understand, talk with our clinician partners, understand the complexity of the model versus the actual implementation and feasibility. Identify meaningful risk scores, so maybe low, medium, and high risk, as well as clinical pathways for those different risk strata. The next step would actually be integrating that into the EHR, integrating and socializing for our pediatric practitioners, and then ultimately evaluating the performance of this in a real-world setting. So we just want to acknowledge all of our team here, including Beatrice Delkina, Eric Rice, and my colleague Claudia Now at Kaiser, and our funding from the National Institute of Drug Abuse. Thank you.
All right, so the next talk is by Karmel Shehadeh, who is an assistant professor in the Viterbi School of Engineering, and will be talking about advancing fairness in medical resident rotation through integer programming.
Thank you so much. Thanks a lot, everyone, for listening. What can you say in 10 minutes? I don't know, so let's see if I can get some through the work. So I'm going to...
I'm so sorry. Would you mind sticking near the, sorry, can you stick,
I have to be here?
yeah,
Okay.
or there's a handheld mic on that podium.
That's
if
okay,
you
I'll
wanna-
just stay here. Okay, so this is my first 10 minutes presentation I ever do, so, okay. So this is based on a collaboration with my colleague here, Beth. She's at Columbia Health. She was at Columbia Health and now Health at NY Logan. So in this talk, basically what we did in this project is medical residents. When you go and see them, see the doctor, there is medical residents. In each year of their clinical residency, they have to rotate through several departments, let's say from oncology to cardiac surgeries and so on. So basically their schedule, their yearly rotation schedule must satisfy a lot of constraints such as training and accreditation standard, departmental staffing needs, vacation requests, program rules, and so on. Now this practice, at least in our collaborating hospitals, they usually do it in paper and pencil and Excel, and it takes them several weeks to construct this rotation schedule. And as you can see shortly that in order to create such feasible schedule is not alone, you also require this schedule to be fair between medical residents. So I'm an optimizer, so as an optimization problem, when we hear that, we try to set it up as decisions, inputs, and outputs. So the decision basically all the requirements to construct this rotation schedule. And the inputs are all the requirements, and the decision is give me a feasible rotation schedule that assign each resident to a clinical rotation, and then also give them vacation during the academic year. The goal, I want it to be feasible, and feasible means that it satisfies all the constraints. What I'm saying here in the note that feasibility alone is challenging. This type of a problem is well known as one of the most challenging integer programming problem in the optimization society. So current models actually can't solve it. In addition, if you want to achieve fairness in terms of assigning vacation requests to residents, that's also added an additional complexity. So we thought about, can we just maximize the number of vacation requests when we create this rotation schedule? The answer is, once you do that, you focus on maximizing something. So you create disparity between residents, with some residents getting their vacation and some not. So what do we want? We want to actually avoid this disparity. So we want a schedule that is both feasible, efficient, and also achieve equity in assigning a vacation request. So what do? We go into our expertise in integer programming. So what we did is, so this is a summary of what the paper have, because I don't have time to talk about all of this. We propose new models because I said even the models for the feasibility problems are challenging to solve, so you cannot implement it in clinical practice. We also design, you got a model, you need an algorithm to solve it, so you need it to be computationally efficient, which we call it the Pareto search algorithm. Also, if I want to give my models to our clinicians, they're not going to implement it. So we developed a tool that they can use it in practice that implement all of this crazy math. And we illustrate the benefits using data from our collaborators. So let me see what I can get now. Okay, so in terms of the model, again, you want to maximize the number of vacation requests, and also you want to minimize the disparity in assigning them to residents. The constraints will respect all the requirements on rotation scheduling. And the outcomes, I need a schedule that is feasible, achieve these two objectives, and achieve fairness. For some of you who are in optimization, they know that this is a multi-criteria optimization problem. So why not use just the epsilon constraint method, which kind of give you the whole trade-off between efficiency and fairness. Again, this is a very challenging problem. So this algorithm, we were not capable to solve any of the instances. So we developed our own algorithm that actually gives you the entire trade-off between a rotation schedule that is efficient and equitable. And this algorithm was much faster. And finally, we were able to solve many instances of this problem. Okay, so now we have this math. Again, can we put it in practice? So hopefully I can get you through some of the insights that you can see in the paper. But before that, the decision support tool. So like I said, there is a lot of math. So we developed this tool that is tested by our collaborator. Basically, we tell them, here is an Excel sheet. Give me all the requirements for this rotation schedule. They're going to upload it. And then they're going to click generate, and then they get the rotation schedule. And I'm talking about a process that has been taking them weeks to do. Now it's going to take them a few seconds. So this tool, they can just use it, don't see the math, in order to get their fair rotation schedule. I know this is a lot, but this is just a computational time. Like I said, these problems were not solved. As you can see in the horizontal line, this is different fairness measure. The colors indicates different instances with different sizes. We were able to generate all the Pareto curve in less than an hour for all the instances. And for those that are actually the practical one, it was within 10 minutes. Okay. Some practical insights. What you see here is different trade-off curves, meaning that each of these points represents different rotation schedule. The horizontal line is the value of, which is the number of vacation requests satisfied, and the vertical one is the measure of fairness, and this is the value of it. Most of these are deviation measure. You can see that this star is the feasible schedule. Remember when I started, I said feasibility alone is not enough. This shows you that this schedule is inferior in the sense that it doesn't, there are fair schedules on the curve that maximize the number of requests and also have a minimum value of the fairness measure. And that's consistent across different fairness measures. Another contribution is we integrated actually both rotation scheduling and vacation scheduling. In practice, sometimes they split them, and also in the literature on this problem. The blue curves are just the trade-off curves generated by, let me give you a feasible rotation schedule and then do your fairness stuff. And you can see that these are inferior in the sense that the orange one, which is generated by our model, can lead to a higher number of vacation requests satisfied and also lower value of the fairness measure. Other things that you can see in the paper, again, what can you say in 10 minutes? I hope you can check actually the paper. The main point is that this is a process that has been done by hand and takes many weeks. Now they have a tool. And this tool does not just give them their rotation schedule, but also can help improve fairness among residents in terms of at least assigning their vacation requests, which is, again, challenging problem in practice, and also from optimization point of view. I think this is the last one. So if you have any question, feel free to ask me after this, or you can also reach me by email. Okay, thank you.
Thank you, Karmel. And the next talk, which will be the last talk of the session, is by Jay Campanelle and our own Bishra Dilkina. And they will be talking about forecasting acute child malnutrition in Kenya.
Okay. Hello, everybody. Thank you so much. I'm Jay Campanelle. I'm an undergrad at Dornsife, and this is Dr. Bishra Dilkina, and today we'll be presenting our work in collaboration with many partners on forecasting acute child malnutrition in Kenya. And I'll hand it off to Dr. Dilkina.
Yeah, hi everybody. I'm so excited to share this work with you. This is again another really collaborative project that involves researchers from the USC Center for AI and Society, collaborators and at AMREF Health Africa, researchers and experts in health at the USC Institute on Inequalities in Global Health, and collaborators at the Microsoft AI for Good Lab. As you all know, malnutrition is a global problem that really needs solving. Over 7 million children under the age of 5 are acutely malnourished in the Horn of Africa. a problem that has a high temporal variability. In particular, demographic health services report over 5% prevalence of acute malnutrition, making this an actual public health emergency. So governments, agencies, and nonprofits are trying to address this. However, lots of the current practices are basically based on data and knowledge that trickles in as the crisis evolves, and it doesn't really leverage any kind of statistical data-driven analysis on a timely basis. And that lack of ability to forecast means that there's delayed detection, which leads to late interventions. Late interventions and insufficient resource allocations, in turn, lead to more severe, longer-term health impacts and higher mortality among these children. Because of that, our team decided to assess the feasibility of building a machine learning model that is able to forecast acute malnutrition among children at not the national, not the county, but at the sub-county level, trying to provide something that is more precise and enable better intervention action. In addition to that, we also wanted to see whether we can get better performance by combining information from both clinical settings as well from satellite-based environmental information on food availability and be able to predict, forecast malnutrition rates at different time horizons, including 1 month, 3 months, and 6 months in advance. Finally, in supporting this model to practice translation, we need to make sure that we have a way of putting those forecasts in the hands of the end users and the stakeholders that are actually going to take action on the ground. So we're also trying to build an accessible dashboard that can serve these forecasts readily. So in our study, we aim to use this clinical and environmental data. And for the health data, we focused on using information from the Kenya Health Information System by closely collaborating with the Ministry of Health. The Kenya Health Information System is built on top of DHIS2, which is an open source, freely available, web-based platform for health information system that is used by more than 100 countries across the world. So in this system, we basically have available monthly information across all of the health clinics in the country being submitted and available. So we are going to use this system to extract clinical features as well as our malnutrition outcome. For the food security, we're using gross primary production data using, this is derived from the NASA MODIS satellite, which again is freely available around the world at 8-day and 1 kilometer resolution. And that data can give us a signal about crop production, which in turn is related to food availability. When designing this, we actually specifically focused on using data sources that are not surveys that are done 1 in 5 years or once a year, but are actually readily available at regular intervals and at high resolution and also available in a timely manner, such that any model built on top of them would actually be able to be deployed and used to forecast what will happen next month, in 3 months, or in 6 months. So I'm going to let Jay explain to you our methodology.
So to talk about the clinical data specifically, we had over 18,000 clinics from around the country, and this, like Dr. Delkina mentioned, is collected on a monthly basis. So you can see all of our clinical variables that we're collecting, and these were selected by our nutrition and health collaborators at USC-CAIS and at AMREF. And then for our specific outcome that we're actually predicting, we use the mid-upper arm circumference, or MUAC, which you can see a photo of below. And this is measured for every single kid who comes into a clinic. They are measured and they're put into one of 3 categories, whether they have a normal, moderate, or severely malnourished, if they're moderately or severely malnourished based on their MUAC. And then to take these features, to take this raw data and convert them into features that we can use, we go by aggregating on a sub-county basis, and then we take the rates based on the total number of kids that entered into every clinic every month, and then we turn these into rates that we then feed into our models. And then for our malnutrition outcome, we do a very similar thing and get a monthly malnutrition prevalence by calculating the rate per sub-county. Then to standardize this and make it so that all agencies across government, the UN, NGOs can understand our results, we're not actually predicting on the percent of malnutrition, but we're using the Integrated Food Security Panel's classification on malnutrition, which is a 5-bin classification with different amounts of prevalence. And this is standard across many agencies across the world so that everyone can understand the results that we're getting. And then for our satellite and MODIS data, we get a raw image of what the production for a month is for every 8 days, and then we aggregate to a monthly basis and then aggregate to a sub-county basis to be able to get this. And we can actually see that what's so important about this is that there's an inverse relationship. So in sub-counties with really, really high crop production, they have very low rates of malnutrition, and especially you can see in the northern parts of Kenya where there's a more arid climates, there's lower crop production and very high rates of malnutrition. And so to talk about this, once again, as a whole, we take our data, we aggregate to the sub-county level, we turn it into rates, we map this to our 5 bins, and then we put this into our training and testing. And then for our specific features we're doing, we input the past 3 months of clinical data and the past 3 months of GPP data, and then we're predicting on the 1, 3, and 6 months labels for each outcome we're predicting. And then to talk about the methodology, we split our data by time. So from January 21, June 2023, training data, and then so on and so forth. And then for our baseline, we used a window averaging model, and this simulates current practices. So current practices are they kind of look at historical data and they kind of make an assumption on what is the next stage. So our window averaging takes the previous 3 months of malnutrition outcome data, averages that, and uses that as the prediction for the next 1, 3, and 6 months. And then our statistical models, we use because they are able to capture the nonlinear relationships between indicators in our prediction target. And we tried many, many models, but today we'll just be talking about our gradient boosting model because it was our best performing model. So to talk about results, we can see we trained 3 variations of our XG boost model on different sets of data, 1 for just clinical data, 1 for satellite data, and 1 for clinical and satellite data. You can see that our satellite data alone gets about the same performance as the baseline window average. But then once we include the clinical data in our machine learning models, we greatly increase performance. And we have our best performing model being the clinical and satellite data. And you can see across 1, 3, and 6 months, even though we're predicting further into the future, there's little degradation onto the accuracy of our predictions. And then breaking that down into the bins we're predicting, you can see that our greatest improvements are on the 10 to 15 and 3 to 10 bins, which are so important because these bins are the ones that can help prevent malnutrition earlier by stopping it before it gets worse. And unfortunately, you can see that we have really, really high accuracy on the 30% bin, but that's typically because, unfortunately, sub-counties that are in those bins are constantly in those bins. And so we always know which ones will be in the greater than 30%, and they will always be receiving aid. And so we took all of these models and we created a dashboard that is live at AMREF that our stakeholders are able to use to understand where they may need to change resource allocation. In addition, we created a suite of apps to be able to generate these forecasts without any technical knowledge. All you have to do is upload a spreadsheet, and then it will calculate all of these forecasts and serve an updated dashboard for all of our end users to use. And then when developing all of these tools, we made sure that we were grounded and iterative the whole time. We started by talking to them, seeing what is the most useful, and we go back and forth to be able to update and create a relevant dashboard that actually addresses needs and has the features that they need to be able to create interventions across not just our partners, but Kenya national working groups throughout the country. And so hopefully what we'll be able to do is fix the current reactive system where children go into doctors after becoming malnourished, and then they'll be visiting clinics, and the intervention is to treat them for the risk of mortality and their comorbidities. But instead, we're able to have better interventions with preventative measures by having more precise and accurate resource allocation.
So in conclusion, I guess we've shown that we can develop these spatial temporal machine learning models that are effective at forecasting malnutrition at the sub-county level. We have used data that's readily available and it's based on DHS2 and MODIS satellite data, which means that we've set this up to be easily replicable among other low and medium income countries in the region that also suffer from acute malnutrition, high prevalence. So we are hoping that this is going to make a real impact and be piloted in Kenya, but hopefully be scaled around the whole region. And in particular, we're hoping that this is going to result in more effective prepositioning of supplies and therefore reduce the longer-term health impacts for children. Finally, we are, again, very heavily engaged with the Kenya, with the Ministry of Health, AMREF, and other actors, nonprofits and agencies, and we are hoping to help Kenya also establish an AI for health and nutrition hub. So thank you for listening.
I thank all the speakers for staying on time. If I could invite all the speakers back so we can take some audience questions. We'll do a quick question answering session for perhaps 10 minutes before we break for lunch. We have 2 mics on the aisles for
And you can
folks
grab the other mic on the podium for the panelists. Inside the podium?
There's no mic, no. Oh, see.
Okay, perfect. Come up here. We don't have to cluster behind the podium.
All right, while our audience is warming up, I do have a question. So a lot of you presented tools, for example, Karmel and perhaps Vidur, and some of the challenges that can come with this work is like actually having the tool implemented and used. Did you face any of those kinds of challenges, or were your community partners like they're already implementing it and they're giving you feedback on the next problem? So just wanted to get an idea of where things are.
So what I presented today is a result of many years. So we started with, here's the code, try it, and that was terrible. Then we created the first version of the tool, and they tested it. They started putting things wrong in the template because they said they have to fill out the template. So we had to iterate and make the template very comprehensive to avoid that. And we put some stuff in the model that prevent them from, putting these wrong inputs. However, now we're facing an issue is that the tool actually uses Gorobi. Gorobi is not for free. So how can you then give it to them? So they have to download a couple of stuff on their computer. If it's an academic, like CAIS school is fine. If the health system is not an academic, that's probably a challenge. So yeah, bridging the gap between theory and practice is always challenging, but I'm happy to see finally a tool working and now. But this is after many years of working on it, yeah.
Sonya or Vidur, you want to say something? I mean, we are not there yet.
Sure, yeah. We're not yet at the kind of dashboard integrated tool phase, but it is really exciting possibility for us. I think one thing just going off of Jay and Bistra's presentation that just happened is how do you go from a score to something like the phase 1, phase 2, phase 3, phase 4, phase 5 type system where it's discretized and it's a measure that your collaborators can readily understand. So building out that transition is something that Sonya mentioned in our last slide, which is one of our main next steps. And then another thing that has been challenging, even when we were just doing internal tool building for sharing model results across parties, it was Kaiser as a health system has stringent requirements on what tools their researchers even can use. So how do we make sure that it's respective of patient data and able to be easily integrated into their EMR is a whole nother set of challenges that we have to overcome. Yeah.
Thank you. Hi, my question's for CounselBench folks. Thanks for your paper. There's many people in my lab who are working off of it, including myself. My question is around the safety and risk assessment part of your paper. How did you come about the definition of safety and risk? As you mentioned, it's very subjective. Was it based on national therapy standards, protocols, things like that?
So thank you for your question, and we are happy that the CounselBench are the things that you're working on. So for the standards, for the benchmark, in one of our authors, he's a licensed psychologist, so we consult him a lot regarding the benchmark design. So as you can see that the 6 dimensions we propose are not very can be understandable by the normal users. So that's another purpose for this benchmark. So we want to present like the benchmark that can be useful for the psychologists as well as for the general users. So the design is mostly dependent on the consultation with the psychologist. Yeah.
Thanks.
Other questions? Please don't be shy. Do the speakers have questions for each other?
Hi, thank you all so much for your presentations. I have a question for John as well. So in your presentation, you talked about kind of comparing human therapists to the LLM models, and there was one graphic you showed where humans had consistently underperformed compared to the LLMs. So could you go a little bit more into kind of the evaluation criteria for that and what you kind of noticed?
Yeah, maybe I can explain more a little bit. So actually, so first of all, our human therapist answers are scripted from the online platforms. So even though they are licensed, but they are not like golden answers. So it is possible that they may have some bias on their own because like the therapist may be rushed to provide an answer online. And then regarding the 5 dimensions where LLMs outperform human therapists, for example, I think we observed that LLMs are more patient and providing more empathetic responses than the human therapist. For example, the human therapist may provide very straightforward answers, while the LLMs are more like empathetic and then like showing, okay, I understand first, and then here are the things you want to try. So I would say like emotion, emotional support is a big difference we observe between the LLM responders and the human therapist.
Yeah, and just to add up to that, as far as like how we sort of compared the two, if I'm understanding the question correctly. So as Yahan mentioned in the slides, we recruited the 100 or so professionals to essentially rate these LLM responses based on sort of different metrics that Yahan had mentioned. And then also, so it was blinded, and then there was also we included the original sort of like council chat response as well. Yeah. So
Thank you.
compared it. Yeah.
All right, let's thank the speakers again. And we'll now break for lunch, and we will be back for the rest of the session at 1:05 p.m.